All right, let's dive into one of the most common and, frankly, one of the most mishandled symptoms we see in practice, dizziness in our older patients. In this explainer, we're going to completely reframe how we think about this problem. We're going to move away from that frustrating hunt for a single cause to a much more powerful multifactorial mindset.
So first off, let's just get a sense of the scale here. We're talking about a staggering 30% of adults over 65 living in the community who report significant, regular dizziness. That's nearly 1 in every 3 older patients walking through your clinic door.
And, it doesn't stop there. As people get older, it gets even more common. Once you're looking at patients over the age of 80, that number climbs to over 50%. So this is not some niche issue. It's a core, everyday part of geriatric medicine.
And the impact, it's massive. Dizziness is consistently one of the top 5 reasons older patients see their GP. And it's not a benign symptom, not at all. It's directly linked to falls, to hospitalizations, and even to mortality. Yet what happens so often, it gets dismissed as just part of getting older, or it's treated empirically with suppressants. Both of those are really costly clinical mistakes.
Okay, and this right here, this is the absolute heart of the matter. This is the key takeaway. Research, going all the way back to landmark studies, shows that older patients with chronic dizziness have, on average, 3 to 4 things going on at once. So think about that. If you're out there hunting for one single unifying diagnosis, you're pretty much set up to fail from the get-go.
And this slide just says it all, doesn't it? We have to make this fundamental shift. We've got to move away from that old mindset of trying to find the cause and embrace this new, much more effective mindset of finding the causes, plural. I'm telling you, this is the single most important conceptual shift you can make when managing these patients.
So let's give it a formal name. Dizziness in an older adult is a multifactorial geriatric syndrome. It's so helpful to put it in the same category as things like delirium or incontinence. Why? Because it's rarely caused by just one thing, it's dangerous to ignore, and most importantly, it's often improvable once you start picking apart and treating each of those contributing factors.
So, how do we make this practical? Well, here's your framework. These are the 6 key systems you absolutely need to have on your radar for every single older dizzy patient. Just think of this as your clinical checklist.
First up, the vestibular system. Now, this includes a general age-related decline in inner ear function. We call that presbyvestibulopathy. But an even bigger one to watch for is benign paroxysmal positional vertigo, or BPPV. It's specific, it's highly treatable, and you would not believe how often it gets missed.
Number 2, the cardiovascular system. This is all about blood flow to the brain, right? So we're looking for things like orthostatic hypotension, that blood pressure drop when they stand up, or postprandial hypotension, which happens after meals. But you also got to keep arrhythmias and even structural problems like aortic stenosis in mind.
Third is vision. And look, this is about more than just reading the eye chart. We're talking about cataracts, macular degeneration, and something as simple but crucial as a patient wearing their bifocal or progressive lenses while trying to walk downstairs. That can seriously throw off their balance. Fourth on our list is proprioception. That's the body's own sense of where it is in space. The common culprits messing with this are things like diabetic neuropathy, cervical spondylosis, and sarcopenia, that age-related muscle wasting. All of these things just chip away at that internal sense of stability.
Coming in at number 5, we have the central nervous system. Things like cerebral small vessel disease, Parkinson's disease, or normal pressure hydrocephalus can all show up with dizziness or imbalance as a main feature. Basically, they mess with the brain's ability to process all the balance signals it's getting.
And last, but definitely not least, number 6. And honestly, this might be the most important one because it's the single most modifiable contributor, medication. From blood pressure pills to sedatives to anticholinergics, polypharmacy is a massive, massive driver of dizziness. A careful medication review here can deliver some huge wins.
Okay, so we've laid out this whole framework of 6 systems. But let's get to the bottom line. Why does adopting this mindset actually change outcomes for our patients? What's the real clinical payoff? It all comes down to this idea of additive risk. See, a patient with just a little bit of vestibular decline might be doing okay, but then you add a new blood pressure med, their cataracts get a bit worse, and some neuropathy kicks in, and all of a sudden, they're falling. Each little problem stacks on top of the others. Our job isn't to find one magic bullet, it's to trim a little bit of risk from each of these systems. That is how you make someone more stable.
And let's just zero in on one of those highly treatable causes we miss all the time, BPPV.
Just look at these numbers. It's present in 9% of older adults who fall, but that number skyrockets to as high as 40% in older adults who fall and actually get injured. This is a huge, treatable target hiding in plain sight.
And that leads us to a really critical clinical pearl. You need to perform a Dix-Hall-Pike maneuver on every single older patient who comes in after a fall. The reason is that 2/3 of patients with BPPV won't tell you about those classic head position triggers. You have to go looking for it.
Thinking this way also helps us avoid something I call the suppressant trap. It's so tempting to just prescribe drugs like prochlorperazine or benzodiazepines, but it's often a harmful reflex. These drugs don't just sedate, they actively stop the brain from compensating. They directly impair balance, and they crank up the risk of falls and cognitive decline.
And hey, this isn't just a nice theory. It's backed by solid evidence. The original Tinetti trials and all the studies since have shown again and again that a multi-domain intervention where you address vision, meds, balance training, and orthostatics all at once is way better than any single treatment for reducing both dizziness and falls.
So if we boil this entire explainer down to its essence, this is the new clinical mandate. It's a simple 3-step plan. First, find every single contributor across those 6 systems. Second, trim the risk from each one you find. And third, actively avoid the trap of just prescribing suppressants.
Now, this framework is powerful, but how do you actually use it in a busy clinic? Well, that's exactly what we're covering in our next explainer, Multifactorial Workup at the Bedside. We're going to distill this all down into a 10-minute, 6-domain exam that every older dizzy patient deserves. This is what turns the idea into a real, actionable plan.
Thank you so much for watching. To explore more about dizziness, vertigo, and imbalance, and to get access to a bunch of great resources for clinicians and patients, please visit our website at australiandizzinessclinics.com. And, of course, please subscribe to our channel and leave a rating.